further ado, Dr. Asirvatham.
Okay, thank you very much. We'll spend about half an hour focusing on trying to get a heart to a state where ventricular fibrillation simply isn't possible. It's a tough road and requires a lot of creative thinking, trial and error, and I want to share insights into both what we've done in our group and what's available from the rest of the EP community. So disclosures, really not speaking about any technology or device that I've personally invented or in the process of commercialization. This is kind of a basic background type talk. To give you an idea of the impact of solving this problem, nothing makes people die more than ventricular fibrillation. You'll have to actually get and put together all the mortality from all the cancers to try and beat what ventricular fibrillation is in terms of mortality impact. In fact, sudden death in many ways is equivalent to ventricular fibrillation. Now, we of course have a Nobel Prize winning breakthrough for sudden death, and that is the ICD. The problem though is we need something far, far, far better. The ICD is really an insurance strategy, and as I'll explain, has tremendous limitations. What we have to and have been exploring for this last decade is what can we do beyond the ICD? Where are we at with VF ablation, substrate modification, and autonomic modulation for ventricular fibrillation? And why do we need something beyond the ICD? It's simple. The ICD does not prevent ventricular fibrillation. It's an after-the-fact treatment. Patient get it, and to prevent death, they get a painful shock. And the pain from these shocks and the fact that the underlying problem giving rise to ventricular fibrillation has not been addressed gives rise to an awful quality of life. Every year we have patients who come up to us and say, turn off the defibrillator, I would rather take death than the fear of ongoing shocks. In the people that are able to continue with the ICD, it's almost like a post-traumatic stress syndrome. They have anxiety, they have nightmares, and just kind of waiting for when that next shock is about to occur. So why hasn't ventricular fibrillation been a viable target for the innovation and practice community in electrophysiology? Well, it's a very, very tough nut to crack, and I'll go over with you what we know progressively in terms of the substrate. What's the raw material that allows ventricular fibrillation to occur? The triggers, what is it that starts ventricular fibrillation in a patient who's in normal rhythm? And then the modulators. Why on a particular day? Why at a particular moment? Even though they have the substrate and they have these triggers floating around. What we know the most of is the triggers. And in other words, someone's motoring along in sinus rhythm, and then bang, they're in ventricular fibrillation, polymorphic ventricular tachycardia. And if we look to see, the trigger is often a familiar culprit. It's something they may have been having all along, and it's usually a PVC. And what's special about these PVCs is they tend to be fairly closely coupled. Something about their origin that I'll explain makes it possible for it to occur almost within the refractory period of the ventricle. And the origin of these PVCs is often in the conduction system of the heart. This is one of the earliest reports in the literatures from our group, which showed that a patient, one of those that we never forget, this was a young lady from Mexico, very active, would climb mountains, do anything that you and I, or at least I, just won't even think about doing, but just shopping. She fell at VF. Someone noticed her QT interval was long after the event and misdiagnosed her as long QT syndrome. She got put on various drugs and would have tons of shots. Just in the month before we saw her, she had 50 ICD shots. And when you just put a monitor on her, this is what you see. You see her motoring along and then ugliness. But in between, there was always the same beat that would trigger these episodes. So we thought about this trigger-mediated VF and targeted this for ablation. And often, these are from the conduction system. Now actually, conduction system arrhythmia has been known for decades. But the usual face of conduction system arrhythmia is a right bundle branch block type of sustained, benign, well-tolerated ventricular tachycardia. So this is what we're used to for decades. What we didn't realize initially is that there is another face for this arrhythmia where it's not a sustained ventricular tachycardia, but just triggers episodes of ventricular fibrillation. Now, what do I mean by conduction system? Sometimes fellows and trainees, those new to the field, will ask, well, where is the heart's conduction system? Well, as you'll recognize from this century-old figure from Dr. Tawara, it's easier to ask, where isn't there the conduction system? It's not that picture from medical school where you have a bundle here, a branch here. It's actually all over the place, but it's always endocardial in humans. We do not find conduction system epicardially, and we do not find conduction system commonly near the base of the heart of the left ventricle. We do sometimes, but so far never been a heart where the conduction system is on the epicardial surface. And this is an important point, I think, in terms of driving innovation on how we try to engineer solutions for ventricular fibrillation. So here's an intracardiac electrogram. This is the EKG all of you are familiar with. And this is like the EKG from catheters placed in the heart. And if you notice this sharp spike-like signal in front of the PVCs that trigger ventricular fibrillation. Sharp spike-like means very quick conduction. And the only thing in the heart that conducts that quickly is the specialized conduction system of the heart. And this is what we see time and again when we map the triggering beats for ventricular fibrillation, including my patient. More interesting is when we just touch that spot, and even worse when we try to ablate to that spot, it triggers ventricular fibrillation. And during that ventricular fibrillation, even though we have chaos on the EKG, the local spike-like signals are rapid and regular, strongly suggesting that they are the drivers from which this chaos is spreading. Now this is a little bit like going hunting and trying to kill a Bengal tiger with a little needle and just poking him and saying, hi, you'll be torn to shreds. It's the same thing when we try to start ablating at that spot. It goes crazy. You have VF after VF, and in this particular patient, I had to shock her 30, 40 times while we were trying to complete the ablation. So it's extremely scary. It's a tough procedure to do in this patient population. But when you're done, it's done. It is something that just makes the problem go away as far as we can tell. This patient, since that ablation back in 2007, 2006, has never had another episode. Every Christmas, I get a little card from her that says, "Thank you for what you did." It's a picture of her climbing some mountain, always a little bigger than the last. And there's always a little PS that says, "Can I take my defibrillator out?" And I always send a reply after New Year's. This is my usual backlog that says, "Great to hear you're doing well. PS, no." because we don't know the natural history. But maybe one day we will. This conduction system is not exclusively in the left ventricle. We do have this thing called the moderator band that takes the right bundle to the different portions of the right ventricle. That can be also a source for this fibrillation. One of the clues we find when we map, this is an electroanatomic map, red means that's the spot. And here we have a red and another red. How come? How can it be two spots that are giving rise to something? Well, what it is something in between that conducts super fast, almost simultaneously to these two sites. So clue often when doing these procedures is multiple early sites that tell us this is conduction system. Clinically, these are recognized as closely coupled PVCs. In the lab, we find this conduction system consistently before the triggering beats as well as during ventricular fibrillation. Now, sometimes we actually don't see this sharp signal before the triggering beat, the PVC, but we see it during a sinus beat. It still means that there's conduction system nearby in that site, and it still means that when we start ablating, we can get periods of ventricular fibrillation. Now, something that has come to light is a common site for ventricular fibrillation in the heart is the endocavitary structures. What these are not the endocardial surface, it's not the mid-myocardium, it's not the epicardium, but it's structures that jut into the ventricular cavity. This was the first case report in the literature, came from our group, which showed that sometimes when we look with intracardiac echo, we can see that the catheter that identified the trigger site was on a papillary muscle. Since that time, this has become extremely well recognized with multiple large case series in the literature, clearly showing that the papillary muscles are special. And they're special both for ventricular tachycardia, the usual form, and for ventricular fibrillation. Now, ablating in the papillary muscle itself is not easy because it's doing a job and we can't kill it completely, otherwise the mitral valve isn't going to work. So careful mapping, finding the spot and trapping the abnormal conduction tissue there is what we do. Now, is it always the papillary muscles and the Purkinje network? The answer is no. Sometimes it's another familiar site that we've known for years as a benign source of ventricular tachycardia. This is the outflow tract. And for those of you who look at EKGs routinely, it's very easy to recognize because you see a left bundle branch block, meaning the left ventricle is late, starting in the right ventricle, and 2-3 AVF, the inferior leads are strongly positive, suggesting origin away from the feet near the head, which is the outflow tract. Now, sometimes, instead of that VT, it's PVCs, closely coupled that trigger ventricular fibrillation. And these can also be targeted for curative ablation, at least in the follow-up period that we have. It appears to be a curative ablation This time it's in the outflow tract. So what's special in the outflow tract? Well, here's an example from a patient. This is a different mapping system. The white is the early spot. So during a PVC triggering VF, this is the origin. What's special here? Well, look closely. This red labeling I've done is the pulmonary valve. Think about that. The origin of this triggering beat is above the pulmonary valve. Heart is done over at the pulmonary valve. How does this happen where it starts in the artery? Well, the heart is actually not done at the level of the pulmonary valve. There are, in many patients, sleeves of myocardium that extend for variable distances into the great artery. And it appears that these sleeves may be the source of triggering ventricular fibrillation in some patients. This is another very memorable case. Young medical student, ventricular fibrillation, multiple VT discharges from the ICD, multiple prior procedures. But what we found in this case was actually the triggering beat was conduction system in the outflow tract. Now we usually think of conduction system in the inflow of the heart. However, remember in the developing heart, we have these dead-end tracts, fibers that go all the way up to the valves, and presumably in some patients they don't go away, they stay there, and when they stay there, they can trigger VF, much like conduction system anywhere else. This is an example from that patient where we mapped and found these spike-like signals firing away. Essentially, this portion of his heart was always in ventricular fibrillation, but fortunately the valve was acting as a bit of a roadblock that he had the episodes only sometimes. We mapped this, and it turned out that the actual fiber was in the left main coronary artery. And however good an electrophysiologist I pretend to be, I don't know how you can ablate in the left main coronary artery with heat and not kill the patient. So we took another approach where we just ablated at the valve annulus and just further trapped these above the aortic valve. And fortunately, that's worked for him. He just graduated as an orthopedic resident. Other times, this syndrome is recognized in an exercise test. By and large, benign PVCs go away with exercise. Bad PVCs stay with exercise. Awful PVCs that can trigger VF increase and actually can trigger VF during exercise. So it's an uncommon syndrome, but almost always when we see that, it's a familiar syndrome in terms of when we find the site, sharp signals, and in this case, it was arising from the moderator band, presumably getting stretched more during exercise. Now, one of the innovations that has helped with doing these procedures are the microaxial blood pumps, the Impella devices that became available to us 6 years ago, that when we can use to support the circulation, so we don't have to keep shocking when we induce VF, especially during the ablation. I think they've made a big difference and at least gives us some more confidence in tackling these cases. Since that time, these have been used with some success, still not perfect because we're not supporting the right ventricle and we can't forever be without shocking the patient. Well, that's the trigger story. What do we know about substrate and modulators? Well, first about modulators, here also we have a familiar culprit. It's the autonomic nervous system. Now, the autonomic nervous system with regard to the heart is very complex. We have an internal autonomic nervous system within the pericardial space, stuck on the heart, the so-called small brain of the heart. We have the extrinsic cardiac nervous system, the spinal nerves and the sympathetic ganglia. We have the central nervous system inputs for the autonomic output. We also have these unique cells, the interstitial cells of Cajal, also stuck in the heart, always hanging around. No one knows what they're doing, but always hanging around near the autonomic nerves. All of these have become game for innovative strategies to try to modulate and play. I'll introduce a few of them. Perhaps one of the big breakthroughs was the recent understanding that the cardiac input, the cardiac nervous system input from the brain actually splits apart at the level of the dorsal motor nucleus. As a result, approaches to non-invasively place stimulatory or blocking current electrodes in the central nervous system have become explored. The one that we've used in our lab is using the venous system as a way to try to get the electrodes up into the brain. Another has been epicardial and mediastinal approaches that try to get to the vagus component of the autonomic nervous system while retaining electrodes on the heart, so you can, with a single electrode system, detect the arrhythmia and then try to do some modulation of the nerve. Several others have been explored. The oldest and well known in the pediatric literature for long QT syndrome and catecholamine sensitive polymorphic VTs is the stellate ganglia. But now the main innovation has been looking at non-invasive methods of stimulation, or at least non-surgical methods of stimulation and blockade. One of the most intriguing ones is one that was actually developed by an orthopedic surgeon. So never again say that orthopedic surgeons can't think. This is a great idea which was noticed by the orthopedic surgeon. While doing back surgical procedures, there were tremendous autonomic effects that actually made them turn the patient over to prevent asystole. So they kind of took it further in collaboration with EP. I served also as a helper for this idea, but using either input from the back or from the vasculature to stimulate the hypogastric plexus, one of the unique areas in the body where we have both sympathetic afferents and vagal afferents mixed together in about equal proportion. Well, the tough one is substrate. The tough one is substrate. So in other words, the best way to cure an arrhythmia is take away the soil. If you just can't get the arrhythmia, it's not going to happen. That's ideal. But what is the substrate for ventricular fibrillation? Here's why it's tough. If you think about ventricular tachycardia, a normal heart will not allow sustained monomorphic ventricular tachycardia. It's always pathology, and the pathology is some kind of fibrosis or scar. That's the substrate. That's given us great targets in the world of VT ablation. But VF is different. If any of you give me access to your femoral vein and 15 minutes of your time, I will have you in ventricular fibrillation. It's something that the normal heart can do. That's what makes it hard to figure out what's the substrate. It's something that's every one of us had, that maybe if it wasn't there, we won't get ventricular fibrillation. So what is this? We don't know what it is, and it could be a combination of many things, but strong data suggests that it is the Purkinje network. So how do we know this? Well, it's first actually from a very old study that was sort of ignored in the literature, I think, except for their own group. And this was using optical mapping during ventricular fibrillation, and showed that the epicardial surface appeared to be a bystander. So this was a really important clue. The epicardial surface is a bystander. In other words, whatever this substrate is for VF, it's endocardial. And if you look at structures that are exclusively endocardial, the only one that's consistently so is the Purkinje network. Further, in similar models, when you give Lugol's iodine is a specific toxin to the Purkinje network. You no longer can maintain ventricular fibrillation. You can get VT, you can get sustained rapid rhythms in the ventricle, but you cannot get ventricular fibrillation. The problem with innovation to try to leverage this important piece of information, in other words, make the Purkinje go away. The problem is the Purkinje is everywhere. So to take an ablation catheter and move it around is very tough. And if you ablate that amount of tissue and you create lesions in the muscle, you may cure VF, but there's no heart left behind. So that's the real kernel for where creative thought is needed to further this field. How do you do that? Well, several things have been tried. Let's take a look at a few of these things. One study, this was from our group, was to try to extract the Purkinje network. So in a Langendorf preparation, first visually looking to see where the Purkinje may be, getting some recordings to see that you have Purkinje signals, and then just physically extracting it, and then doing a RNA stabilization, transcriptomic arrays to see what's different that we could perhaps try to engineer around. And it turns out that there are many things different. The best combination was ANP. The only source of ANP, atrial natriuretic peptide in the ventricle, is the Purkinje, along with connexin 40. Can tag these to light them up to see where they are. The idea is maybe to create a biological system that will make the infrahisian Purkinje go away. Now, how to do this and how do you select which part of the conduction system needs to go away? Well, there are some important clues into the nature of our human conduction system. The one we want to retain is the part of the Purkinje or infrahisian conduction system that has a fibrous sleeve around it. The His bundle, the left bundle, the fascicles. The one that has tremendous redundancy and in many ways is an evolutionary vestige is this interconnecting distal Purkinje network. Now, this is interconnections may be what allow the wave breaks that are needed to create and maintain ventricular fibrillation. So the idea then is to target these guys. They could be biological. Another key area of looking at this is using at non-ablation or non-thermal ablation energy sources. And the one that Paul, others, and ourselves have been very interested in is DC current at very small doses, which essentially electroporate the cells. Now this electroporation, because it's non-thermal, we don't worry about coagulum formation. And it may be more superficial or can be made to be more superficial to allow targeting of the Purkinje that's non-insulated without damaging the insulated portion and without damaging too much myocardium. Another very interesting innovation also from our group that's been spearheaded by my colleague Dr. Douglas Packer along with colleagues in Germany is the use of the carbon beam particles. A carbon beam, as you know, has been recently used in biological therapies because of its exquisite 10 power 4 increase in spatial resolution. And using this to ablate specific structures non-invasively gives us the out that we could do multiple sessions and ablate only a minimum amount, maybe targeting the endocardial surface. So if I summarize, and before we go over what I hope will be many questions from you, VF is a viable target. It's not something special or something that we just cannot think about to create a cure for. It is an arrhythmia like anything else that has triggers, it has substrate that is needed to maintain it, and modulators. While we've made the greatest progress in triggers and modulators, substrate is the most recent and hot area for innovation and research. There are many approaches that are possible. Whatever that approach is, it has to solve the problem of targeted ablation, saving what we need, and keeping the myocardium intact. Thank you very much for your attention.
All right, we have plenty of time for questions, and got hands up already. Perfect.
Thank you. That was truly a fantastic and an innovative talk. I have a question about the bundled branches, the left and the right. Before I ask my question, perhaps I'll give you an analogy what I'm thinking about. If you have an electrical wire and that wire was to break, you could physically join the wire somehow using an electrical tape perhaps. If during the EP study you can accurately find the location where the branch has broken, could you go and join that left or the right branch perhaps using some surgical means or even a conductive gel to prevent further problems downstream?
Right. Well, thank you very much for that question. So first, the Purkinje network, why it gives rise to VF is not that it's broken. So in other words, the fibers themselves are probably normal as far as we know. But somehow, because it's such an interconnected network, a single PVC multiplies into like multiple near simultaneous areas of activation. So it's like showering the heart with multiple PVCs. That's probably why it happens. There are other reasons. To get an arrhythmia like VF, you need something to create a wave break. The way we think about wave breaks is normal tissue meets a scar, so it's forced to split. Meets another scar, is forced to split again, and before you know it, you have chaos. But here you have a reverse thinking for a wave break. You actually have normal tissue that now meets supernormal conducting tissue, and that produces the wave break. Now, the broken conduction system is what causes bradycardias. And indeed, there are approaches that have looked at biologically trying to repair these breaks. They've been difficult mainly because it's tough to keep contact with the endocardial surface. You always have to worry about stroke. Any gel, anything that even a small little bit breaks off, that's a devastating stroke. But some innovative approaches have looked at that and actually trying to carve out within the myocardium small conducting tissue wires, very, very small, either graphene or graphene-like in their constitution, and put into the myocardium itself, so no chance of embolization, and to see whether we can get this conduction to other parts of the heart. But that's kind of where that field is.
Question back there.
Yes.
Two questions, both on diagnosis. So PVCs are relatively common. So you can sort out PVCs for this issue based on exercise tolerance, or is that the kind of the litmus test?
Okay, so it's an important question. So many people have PVCs. Who's at risk for ventricular fibrillation? The answer is we don't know. We don't know how to risk stratify except after the fact. after they've had their first event. However, in analyzing these patients after the fact, there are some themes. The PVC morphology suggests origin in the conduction system. The initial upstroke is very rapid. The time from the start of the PVC to its peak is less than 100 milliseconds. The coupling interval, meaning how quickly after a normal beat it arises from, is almost always less than 200 milliseconds. That's very, very short and not common in terms of the PVCs. But this is why it's so important for research to target substrate. Because I don't think we're ever going to be able to sort out which trigger is bad and which one isn't. But if we take away the soil, then there's no way the weeds are going to grow. The problem is we have to make sure the plant stays alive. That's the problem and the challenge for the next decade in VF therapy. You had another question?
Yeah, so the second one was, so Medtronic just had their approval, or their study where they compared cryocath to RF ablation, and that was really nice. I remember when cryocath came out, everybody was all afraid of it and whatnot. But what was startling in the whole thing that never got any press is the low rate of people that met the endpoints, which still goes back to diagnosis. It's like the success rate of atrial fibrillation is really, really low. Not that we shouldn't go after it, right? But so it gets back to diagnosis. So what opportunities do you see for actual diagnosis for this so we can get maybe a jump on going forward? Are there tools, products, capital equipment, software? What's needed from the innovation side to get a better diagnosis so we can have a better curative approach?
Okay, so just shifting to atrial fibrillation. So one of the things you asked is, well, the success rates for AF ablation are low. That doesn't mean we should go after it, right? Well, you're asking that to an electrophysiologist, and this is the way I'm going to put my kids through college, so you're going to get an unbiased answer. The unbiased answer is, you're absolutely right. I think we've missed any kind of reasonable expectations our patients have for us for atrial fibrillation. And we do need a rethink in this area. And obviously, people all over the world are thinking about it through different ways. The way our research has gone is to the autonomic nervous system. So the same question is there a heart that you cannot get into atrial fibrillation? Just like VF, the normal heart can get into AF. But there is one situation that you just cannot get the heart to fibrillate, and that's the denervated heart. If you denervate the heart, try as you might, you cannot get it to go into atrial fibrillation. So people have tried to innovate around this in different ways. Some I think are crazy, like a group in Russia. They started doing auto transplants. They would take the same patient, pluck their heart out and put it back in, and say you won't get AFib anymore. I'm not going to do that when I get my AFib. But we've taken an approach where we try to denervate the heart with electroporation, with catheters in the pericardial space. Yet to know whether that's going to make a difference or not. Other completely new approaches to AFib that are out there worldwide is to create an electrode system in the atrium that shunts to each other. So because of this, the electricity and the wiring takes current from one side to the other before the natural current can get to that site, keeping those sites refractory, and then you don't get atrial fibrillation. Yet to know if that's going to work. The third approach is to use cooling. A cooled heart does not fibrillate. So to look at ways using like Peltier elements to rapidly cool the heart in both AFib and VFib to try to painlessly stop AFib when it occurs. But your initial premise is right. We do need a rethink to do much better than what we're doing for atrial fibrillation.
So I got to follow up on that then. If you do the ablations of the autonomics, are there any consequences to that patient's exercise tolerance or other parameters?
Well, the denervated heart outcomes where we know is sympathetic ganglion, stellate ganglionectomy, usually children. For long QT, we have long follow-up and nothing happened to their heart function or elsewhere. We have transplant as a kind of natural experiment to say, okay, it's denervated if something happened. But it only will be really long follow-up that we'll have to see. Some of the things we all worry about is, will something happen to cardiac function? Will there be something, because we're removing the afferent limb, will something happen with depression, with awake state, cognition? There are a lot of things that are theoretically possible but seem unlikely because of these natural experiments.
Other questions? All right, I got another one. So with all these advances in these non-contact mapping systems, or just mapping systems in general, are they at the point, or will they get to the point where you can look at these VTs and multifocal locations at least, or even look at some of these projections like the Moderator band or the papillars? Could you ever get to that point where you could identify those structures?
Well, for ventricular tachycardia, monomorphic ventricular tachycardia, we're already there. A combination of merging with intracardiac ultrasound and any of the clinically available mapping systems, we are able to identify single circuit, single scar related VT. It's not hard, and most of the time we can find it, and the challenge is the biophysics of energy delivery to try and make it go away. For VF though, I think it's a very hard thing to do. The resolution that's needed is incredible, way above the frame rates we get from any kind of mapping system today. There is a terahertz imaging probe that's under development that maybe, if that can ever give us enough depth of penetration, and we have probes in the epicardial and endocardial surface, maybe we'll get close. But I'm guessing there has to be a fundamental physics advancement to really allow a point where we can visualize the origin and maintenance of ventricular fibrillation. Who knows? But I have one question for the audience.
All right, go for
How
it.
many of you believe that one day we will create, no time frame, one day we will create a heart that just cannot fibrillate? Raise your hands. Not too many. We don't have much faith in this thing. It'd be huge. It would be huge if it happens, and I think some early clues that it may be possible. Let me ask you again 50 years from now. Let's see.
There's another question over here.
So, do I understand this correctly then, that it is in areas of scarring that you have a hyperconductivity, period? And it is that hyperconductivity which is resulting in, as you put it, a wavefront splitting and subsequently the chaotic pattern. And if that's so, then isn't one of the solutions simply trying to take the scarred area and slow the conductivity, rather than simply trying to ablate it, as we would think of with radio frequency and freezing and so forth?
So, no, it's actually the other way around. So for VT, scar conducts not at all or very slowly and forms a boundary for the circuit. So we actually don't ablate the scar, we ablate the little channels between the scar with pretty good success for VT. For VF, you don't need scar at all. It's the normal conduction system and the gradient, how fast it is compared to the surrounding tissue that appears to be the substrate for VF. Yes?
Last question.
Although it's not part of the ACLS algorithm, can you beta block fibrillating heart and get it to resolve from VF?
It's a great question. So beta blockers are the absolute mainstay for ventricular fibrillation storms. People who get VF, you shock them, they go back into VF again and again. The key treatment is beta blockade. And in fact, stellate ganglion block acts as a type of beta blockade. But beta blockers will never terminate an episode of VF. They are to try to prevent the milieu for reinitiations.
All right, let's thank Dr. Asirvatham. The advantage of him being down at Mayo was a quick trip up here. The disadvantage, he's got patients still waiting for him this afternoon, so he's going to zip back to do his clinical duties. So again, thanks for coming up and spending the time with us. Now we're going to have Dr. Gafoor, and if you were here last year, watched live cases, you're going to recognize this voice.
Hi everyone, thanks so much for having me here. It's actually, this really grew out of a visit that you guys came over to see us over at the CSI conference, and we were so impressed with the Visible Heart Lab and the amount of work that you guys have done at the University of Minnesota that it really sparked a conversation, and that grew into a continued partnership as well as also live cases and so on, and now this address today. But before I begin, I think the first question I had is, how many people in this audience know what structural heart disease is? Okay, good. So this is the biggest thing, because this is more growth than from every year from the year before it. And so the people that don't know what structural heart disease is, I think let's just go through that, because before we can talk about what really the unmet needs are, we should really know what this whole field is. And really, structural heart disease is what's left over. That's really kind of the best way of that I can really think about it. There's the heart failure realm of the world, there's the coronary disease realm of the world. We've done so much progress in that. We heard a great talk about the electrophysiology side. But then now there's this, basically this box of what's left over, and this non-coronary cardiovascular disease processes and interventions that do not have to do with the electrophysiological side. It deals with abnormalities of the valves and of congenital defects. And it's really a large term with a lot of disease processes. And you probably can't read all this from the back, but it really does valvular heart disease, patent foramen valley, atrial septal defect, ventricular septal defect, which are basically holes that exist that shouldn't exist and we need to close them. And then there's left atrial appendage, left ventricular aneurysm, patent ductus arteriosus, paravalvulopathy, hypertrophic cardiomyopathy also falls into this realm, and so on. So a lot of different ways of kind of looking at multiple different things, but what really brings them together is really that this whole aspect of all of this crosses subspecialties. No longer are you seeing one physician, and that means you're no longer creating a device for one physician. You're creating a device that is going to be investigated by cardiac imaging, that's going to be looked at by cardiac surgery as they try to decide what's the best way to place it through a percutaneous approach, a surgical approach, or a hybrid approach. Vascular surgery will be involved in terms of trying to get the device from an access standpoint. Anesthesiology will be involved trying to say, okay, how will this do in terms of the hemodynamic instability as this device is then put into place. This requires new training, and so this basically will require new catheter techniques. So surgeons for the first time are picking up catheter techniques to learn how to get access to cross the valve, to put these things in place. New imaging requirements. We're looking at this to say, okay, if we're no longer able to do this fully visually based on open heart surgery, how can we realize what exactly is there for the measurements for a valve in terms of the diameter? Is it perimeter that's important? Is it area that's important? Is it systole that's important? Is it diastole that's important? Perimeter-derived area, people go back and forth based on this all the time. This creates new delivery systems, new access sites, even physical spaces where these need to be performed. The whole advent of hybrid labs, of hybrid radiology, of hybrid echocardiography, everything that's really putting this all together in place has really grown in many ways because of structural heart disease. And not to mention the economic potential, which is not small. And if you look at this from economics of structural heart, and this is from a slide from Marty Leon over at TCTAP in 2011, so it's already very dated. If you look at this, you can see what's actually growing on from 2009 up to 2019. It went from $0.4 billion to $8 billion in terms of the projected growth, and it's actually probably more than that when we look to see of all the different devices that have come through. So let's talk about this, which is the unmet needs, and I'll go a little bit through aortic valve interventions, mitral valve interventions, left atrial appendage interventions, talk about imaging and access, and then principles for device designers, things that we wish that we could tell you from a community standpoint. And when I talked to Dr. Iaizzo about this, he said, absolutely, that'd be great, and we'd love to hear that. So the basics of TAVR, for people that haven't heard it, really is a short term for transcatheter aortic valve replacement. And instead of the surgeons coming in, cutting out the old valve and then putting a new valve in, what we're trying to do is find some way to put a valve inside the valve. And in the US, it's called replacement purely for economic terms, because that's when you get a better reimbursement strategy. Overseas, they probably call it by a more rational term, which is transcatheter aortic valve implantation, or TAVR. And what you're basically doing, and this is through the Edwards Sapien valve, is really coming across the valve. Here they use a balloon expandable platform, open up that balloon that's there and with the valve inside of it, and then leave everything behind with that valve then stuck in place. So then this brings up issues of not only just sizing, this brings up adjacent structures, it brings up the sense of how this is actually fixated into place, and how do we access all the things that we still need to access as this patient lives on. How do we make sure we get to the coronaries? How do we make sure that this valve functions? What's the durability of all this valve? All these questions come up. And of course, where one company was able to put something forward, multiple companies are able to also put something forward. And you see all these different valves that are available. On this sheet, you can actually see some valves that exist today and are exist in different companies. In A, you can see the S3 valve, for example. C, you see the direct flow valve. D, you see the portico valve, and you see some valves that don't really exist anymore. For example, E, which is the engager valve, which has been pulled off for X and Y and Z reasons. But what did these other valves solve? Why did they move from valve A to these other valves? What were the unmet needs at that time that people went after? The first one was paravalvular leak. And so they saw that a leak around this valve associated with the worst outcomes. So then they put a cup at the bottom of the valve. And I'll get into this a little bit later, but this cup at the bottom of the valve was a mixed blessing, because now that we got rid of leak, we also added to the problem of actually increasing the pacemaker rate, because this would then now impinge on the AV node. And so it's a balance that we see between these two problems. There's also a positioning issue. With balloon expandable valves, had an issue of once you had started, you had to keep going. You had to inflate until you were fully done. So then they created self-expandable valves, for example, the Medtronic's platform, which has repositionability as well as retrievability. In addition, coronary access was a big issue as well. So you want to make sure that you have this valve, which is extending all the way to the ascending aorta. How do you make sure you're still able to get into the coronaries? So larger cells have been thought of to be able to access the coronaries after implant. But this still leaves these unmet needs, which are the issues of today. And one of the biggest ones that's out there still is pacemaker dependency. And it's really an anatomical problem or a pressure problem that we see. And so this is close proximity to the AV node of the heart. Across the board, it's about a 10% risk that we're seeing, and it can be some valves are coming at 8%, some valves are coming at 12%, but it really is averaging out to 10%. And this really is pressure mediated. And when you look at this from a sense of having a cuff that can add to it, you can also think that the more that you reposition a valve, and a valve is now grading against this AV node, you now have a setup for this pacemaker dependency that forms. What can we do next? How can we address this problem? There's a couple ways. First is earlier recognition. How can we find the patients that will most likely need a pacemaker beforehand? And then there's non-invasive testing that people are looking at to say which patients are at risk. Second is imaging. Is there any way for us to be able to track the AV node during deployment? Make sure that we move away from it when we're doing all the manipulation that we're doing. Nobody has done this yet. On fluoroscopy or on echocardiography, even electrocardiographic monitoring, people just even taking a look at the ECG and saying, when exactly are we doing the damage that we're doing? And then of course follow-up. A lot of times people end up getting pacemakers because in the hospital they have a complete heart block, and then their pacemaker is implanted before discharge. You follow them up at 1 month, then all of a sudden the complete heart block went away. Did we actually need to put this pacemaker in the first place? Sometimes you send them out and everything looks great, and then they have a syncopal episode at home 3 days later. Why did we miss that when it came up? Is there a place here for wearable technology? Another big unmet need is durability. And just this past week or two, there was a publication from ACC, there was presented in ACC as well as a publication in New England Journal talking about intermediate risk for patients with aortic stenosis. And with the Edwards trial, this was presented. And this was great because we saw at this early year mark, we saw that it was non-inferior to surgery when it comes to stroke, when it comes to death, when it comes to pacemaker, and so many other things. But we still have this great unanswered question. How long do these valves last? Every time I turn to one of my surgical colleagues, they'll say, we have data for this surgical valve. What do I do with this TAVR valve? How long data do we have? We have one publication that looks at 5-year data and shows what exactly happens to the sapien valve with that. However, if you turn around and look at the actual age of the patients in that trial that was presented, the average age was 81. So somewhere in the mind of the people that are including people into this trial, they're thinking to themselves, am I ready in 2016 to send a 45-year-old to TAVR? And the reason why people are not ready yet, because people don't know the answer to this. 5 years is not enough to be able to really assess what the long-term issues will be. And as we come to lower risk populations, we need to match the surgical durability of 10, 15 years and more. And here's a general setting of just one study that really looks at time from surgery, and on the left it looks at probability for death, and it's saying that it's equivalent for the bioprosthetic as well as the mechanical valves. On the right, you can see the probability for aortic surgery again, and you can see that as the bioprosthetic valves get into the 15-year period, they're starting to hit the 8 to 10% mark. Of course, all of this, and we know this as cardiologists, is really registry driven. And the registries are great at showing things when people input data. But how often are patients actually followed religiously for 5 years, 8 years, 10 years, 12 years, 15 years? That's where we all fall short. So we're a little bit skeptical about this, but we really need that rigor from a study to tell us what's going on. Other unmet needs, delivery sheath and access closure is probably one of the biggest things that we don't know what we're doing with. And the reason why is that we've made only marginal changes in this so far, and we're still trying to figure this out. There's multiple methods for access because there's so many different ways that we want to be able to go in. Femoral arterial, apical, aortic, carotid, subclavian, transcaval. All this you'll see and you'll read, and people will present this. For the vast majority of our patients, 95% plus, we're still going through the femoral arteries in the groin. And every time we go through the femoral arteries in the groin, every single French size that we go up, we have to think to ourselves, can we make it today? Can we get through this 95-year-old lady's 5.3 millimeter vessels with circumferential calcium today with this sheath or not? Can we go sheathless? Can we make it with this delivery system or not? Every single time we are looking at these pictures and really pouring through this, trying to figure this out. And especially in women, patients with peripheral artery disease, Asian countries especially, this is a huge issue. And 14 French is the current standard. But I'll tell you right now, if somebody makes a halfway decent valve and it's 5 or 6 French, you will immediately be a winner in the market, hands down. Because this is such a big issue for us in trying to get them. On the other side of it, access closure. Say you're able to get in, but how do you make sure that the groin is stable on the way out? 2 per close is the most common strategy. So we moved away from surgical cut downs to now suture-mediated approaches, and now we're using something that wasn't designed for this through a jerry-rigged approach where we're doing a per close facing in at 10 o'clock and a per close facing at 2 o'clock, and we're saying this is what's going to work. And then we're putting pressure on the end. Then we start thinking about even reversing with protamine. Then as we reverse with protamine, are we wondering whether our stroke risk is going to go up as well? All those things play into account as we're really trying to decide how this will play out. A great closure approach will also win out. I mean, it's what I always make this joke with Abbott, that Abbott doesn't have their own transcatheter aortic valve, but because they own PerClose, they're selling product with every single TAVR valve that goes to market. It's great for the company because they're just biding their time until somebody makes a better device for this. Also unmet needs, stroke. It's great if you put an amazing transcatheter aortic valve in, you extend people's lifespans, you can do all this amazing stuff, but if you have this 2 to 8% risk of stroke, it's really a life changer. You take somebody that was able to walk but slowly and still had a reasonable quality of life with their family, and then all of a sudden you move them into the stroke category. Now they're bedbound, can't talk, can't eat, all sorts of different things are going on. And for the 30-day stroke, the real rule of thumb that we figured out is that half of these are happening the day of the procedure, half of them are happening after the procedure. So even if you fix something during the procedural standpoint to understand what's happening, you're still only going to get 50% of that better. So people have started to make baskets and deflectors. And every single time we have a basket and deflector, it's great because you can say we're going to now put this in place. But even putting a basket or deflector in place has already shown us to have MRI-based hits in the brain or MRI-based signals in the brain. Is this actually adding to the problem as opposed to taking away from the problem? that's all what part of the large studies are being looked into right now to try to figure this out. But why don't we use the device in each case? Because exactly what I said, we're still not sure whether just putting the device in is going to cause a problem, number one. It adds to procedural cost as well as procedural time. And if you really wanted to make it that much easier, why not make a delivery system that has a stroke protection device built in? Has a deflector already that comes up as soon as you unsheath the valve to make that work out. It just makes so much sense in my mind, but I still can't find a company to say, hey, this is the direction that we're going to go. So that's on TAVR, and those are kind of the unmet needs of TAVR, and then we'll move into mitral valve regurgitation for a second. So mitral valve regurgitation is multiple causes, multiple etiologies, and some of those etiologies can range from ischemic heart disease to our previous speaker actually burning a papillary muscle and causing one of these leaflets to fly out. We can go from all over the board in terms of this, right? And so it's really a problem with so many different things. And if you look at the aortic valve, which is really very simple, it's 3 leaflets that become calcified and it hardens in one place. I like to think of this as a circus tent, and a circus tent has, of course, the big hole in the middle. It has all those big tent-like structures. That has all those wires on the side. It has those spikes on the side, and any single one of these, in certain different scenarios, can end up causing the whole tent to come down. So similar to the mitral valve. So in the mitral valve, it's really a problem either of the leaflets, it's a problem with the chordate, it's a problem with the papillary muscle, it's a problem with the annulus, or it's a problem with the ventricle. All of those things are involved to different extents. And really, we kind of are making it to 2 very arbitrary classifications. Degenerative, it's a problem with the valve, and functional, it's a problem with the ventricle. And the valve itself is fine, it's just being stretched, and the annulus is being stretched because the ventricle is growing underneath it. Although that's not necessarily 100% the case. Sometimes with ventricle stretches, that valve leaflets are not always staying exactly as pristine as they were when they started. But let's talk about still how surgeons have done it. And when we talk about how surgeons have done it, then hopefully we can find out the very simple, $1 million answer to this question of how do we repair the valve. And the answer is there's really no one way to repair the valve. And if you look at it, I kind of have this old adage that comes up, if there's 10 different ways of doing something, that means there's no correct way to do something, which means there's still a lot more room for us to work to try to figure this out. And if you looked at this, this is just a study of one congenital abnormality, and they talked about different surgeons and how they approached it. So they said of this, 32% of surgeons did an annuloplasty, 20% of surgeons did a papillary muscle fenestration, 12% did an open bilateral commissurotomy, 10% did a quadrangular posterior leaflet valve resection, 10% did cleft closure, 8% did a mitral supravalvular membrane resection, 8% did anterior mitral valve leaflet repair. So if you get a bunch of surgeons in the room talking about how they're going to do mitral valve surgery for the same patient, you're going to get 10 different approaches and 10 different levels of reported success based on how that surgeon feels that this patient would do in their hands on that day. That's really how mitral valve repair has grown. That if you look across the board, there's a few centers doing a lot of surgery with mitral valve repair, whereas the rest of the country, people are doing only 5 cases a year. And the rest of them, they're sending to replacement. And why is this the case? It's because replacement is really easier. It's not hard, just take the whole thing out, put a new one in. But then you put somebody in for a whole line of anticoagulation, you put them in for, then you're now taking rid of the chordate, you're disturbing the way that this valve is now interacting with the ventricle, and you're doing so many different things. But sometimes you have to do that. And historically, we've actually switched back and forth. In the 1950s, there was no cardiopulmonary bypass. So when bypass didn't exist, repair was the way to go, and you did it off pump. 1960s, then cardiopulmonary bypass showed up and was in full force. Open repair was able to be done. 1970s, 1980s, mechanical and tissue happened with more replacement because now these valves are coming forward, and yes, let's use these valves. 1980s, they backed away and said, let's try to think about this a little more, and so ring prostheses came, so repair came back into the field. And so from the 1990s and beyond, there's been this whole thing of doing repair as well as replacement in the right scenarios. Overall, what are the rules of thumb? For degenerative, repair is the best option, but not all surgeons, like I mentioned, are skilled enough to repair all the time, and the replaces are high risk. If there's a calcified annulus, they can't repair sometimes so well, and so they replace as well. Functional, undersized annuloplasty if possible, replacements otherwise not doable. And most surgeons, when they see a patient, they'll say, I'm going to consent you for repair, but by the way, let me talk with you about some of the valves that we may put in if we end up having to do a replacement. Let's talk about mechanical and bioprosthetic valves. And at the end of a 45-minute with the surgeon, the patient's walking out saying, I'm not exactly sure what I came in for in the first place, right? That's what's going on in the surgical field for mitral valves. But let's go to how much we don't know, and let's move away from that. Let's talk about what we've done so far. And what do we have for repair? We have a few different devices that are starting to become commercially available inside Europe. MitraClip is one, Carilion is one, Cardioband is one, Mitraline is one. And how many people in the audience have heard about this, or have heard about these devices? So, and about half of you guys have heard about these devices. We still don't have a great winner. We know that MitraClip has probably had the most implants. We know that some of these Cardiobands looking and saying we can do a popular annuloplasty and that's why we're better. Mitraline is saying we can do an annuloplasty through a different approach and that's why we're better. And Carilion is saying we're the easiest to be able to do and we still get great results. So if you're looking at this from an animation approach, I'm telling you what I'm thinking while I'm looking at this. So if I'm looking at this from a novel operator, yes, so this is great. This is showing that mitral regurgitation, left ventricle is going to left atrium. And I'm looking at this and saying, okay, what's going on? I got this really big, long thing with a lot of different dials on it, a lot of different knobs. Okay, now I understand again what happened. That part of the animation went too quick. I go through the vein, I go up, I go across from one side to the other. How many transeptal axes have I done? How many people can say that they do this on a regular basis? How high do I go? How low do I go? How do I image to make sure that I'm there? Okay, fine, this part has already moved on too fast. But now I'm at this point. Now there's this thing coming out and it's pointing over the valve. And so, all right, it's great, it's pointing over the valve, now it's bending, so I must have had to do something with some of these dials to make it bend. And then now it's positioning over this leaflet, all right? I guess I can bend it in one way, bend it in the other. And I'm telling you this because this is kind of how we're reacting when we look at this. We're saying, all right, how do you make an animation that actually makes the point of what's going on? And okay, I see what's happening. Oh, good, I can actually torque it in one direction to make it perpendicular. That sounds decent. Find out where and this little, 2 seconds that shows that there's a jet coming through, that actually is a very complex maneuver that's happening with the echocardiographer as well as the interventionist both talking through it. And then this then pulls itself up back to the valve and then closes it. Oh, there's still a little blue. I should be happy with that. That looks fine. No, wait, they let it go. Now I got to recapture it again. Wow, this seems like a lot of work, right? And so this is kind of, if you looked at this for the first time, you'd say to yourself, this was so complex. But yet 40, 50,000 implants have been done of this, and this has become easier and easier. So there's hope for us on the interventional cardiology side or on the cardiology side or on the percutaneous repair side, as you call it, to do some of these techniques. But this is still just one of those 8 techniques that I listed before you. And this is just one, which is an Alfieri stitch approach, which many people have looked at and said, that's not enough by itself. You should also have a ring annuloplasty. So here's a ring annuloplasty system, right? So people looked at it and said, let's create one. And so these are people over in the Cardioband division. And so what they're saying is that we want you to come across from this right side to this left side. Okay, I know how to do that because I do MitraClip. And then I want you to come into one of these annuli at one of the corners, get down through, insert a corkscrew, and then keep piling more corkscrews around. If I just got my MitraClip time down to an hour and a half, how long is this procedure going to take? How easy will it be for me to image? How will I convince my cath lab in my hospital to give me this much time to do this procedure correctly and safely? And how am I going to find which patient I'm going to do this first versus another patient? And we know there's MAC, mitral annular calcification. We see it, we diagnose it, blah, 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 blah. What are these patients going to do when they have calcium there? And so these are some of the real world type situations where we're trying to say, when will a patient be a candidate for MitraClip? When will they be a candidate for Cardioband? How do you decide where they one or the other? And that's why many people said, let's just put a replacement option in. Let's move away from all this repair stuff and try to say which patients are great leaflet stuff, which patients are great annular stuff, and say, let's get a replacement, one size fits all. And great, we came up with 4 or 5 different companies have come through. There's the first generation cardiac valve, there's the Tendyne valve, which you see in B, there's the Tierra valve, which you see in C, and then there's a Fortis valve, which is currently not available, but that's one of the other valves that's there. But all of these have really not come through with the same level of safety that the mitral valve repair technologies have come through. Aside from Tendine, many of these are suffering from 30 to 50% mortality rates from doing these cases. And so what are really the unmet needs here? Why are we struggling so much? Some of this is imaging. You know, we have a huge issue with transesophageal echocardiography. We're saying this is the sine qua non. We're using this for each one of these cases, but there's a time lag that happens between the operator versus us, number one. There's a shadowing from calcium. So, okay, the exact place where this replacement valve is supposed to fit, I can't really see anymore. I can't help you anymore. I think this is where it's supposed to go. And you say, okay, sounds good. We'll go with this because we have a CT, we have something else. We're using adjunctive imaging and some memory to try to put this into place. Echofluoral overlay has helped a little bit, but once you put a wire in place or once you've now adjusted something, now things may be off. 3D intracardiac imaging, ICE catheters, if you try to put this, you'd have to really pop this into the left atrium to try to get that better picture. Better transthoracic capability is still not going to be up front just yet. It's a great idea in theory because it's too far away from the mitral valve right now. And cardiac MRI would be a great idea, but all of the things that we use are not friendly towards magnets, so that's where we're stuck. Philip Blanke, who's over at the University of British Columbia, has a great presentation that he talks about CT sizing. So all of this, just like for TAVR, we moved to CT sizing for this. And the things that he's figured out is that the annulus is a 3D shaped saddle. Great, so that was half the problem, is that when the aorta we were looking at a perfect circle. Here now we're dealing with the saddle to try to put this together, so that's one huge issue. The second one is the landing zone differs from patient to patient, so what you're trying to actually anchor this to is a big problem. And a third thing is LVOT obstruction, and this is actually not a small deal. What happens here is that you're now trying to place a valve in the mitral position, and it's a very bulky valve, and where that blue arrow is, you see that part of the aortic valve, that LV outflow tract, which is being compressed. And as it's being compressed, what's happening is that blood can't get through, and this neo-LVOT is not enough, and the patient is now going to come with symptoms of LVOT obstruction. Other things that are issues here, fixation, deliverability, how is it delivered transapical or transeptal. All the cardiologists will tell you, make a transeptal one, we'll love it. All the surgeons will tell you, if you make a transeptal one, what will happen is that you won't get the coaxiality that you want and need in order for this thing to sit well. What does it fixate onto? If it's to the annulus, is there calcium there? The Tendine device fixates towards the apex, and this has been having the best results. At the same time, nobody really knows what the long-term issue will be of trying to create something that attaches to the apex and how that will maneuver after 5 years in place, what will happen to that whole stability of that. It's a dynamic environment with high pressure, and we need to preserve it. One of the early cardiac Q cases that actually happened was that a patient actually had an aortic valve, mechanical aortic valves in position. They put the mechanical mitral valve in place. They had a great LVOT and everything, but then that valve fixation point ended up interacting with the mechanical part of the aortic valve, and then the patient died because the mechanical aortic valve stopped functioning, right? Excellent technical success, horrible clinical outcome. Suboptimal radial force is also an issue for the mitral side, and like I said, the LVOT is small and can easily be crushed. The mitral valve, other things that we need to know is that with patients with prior bioprosthetic valve, which valve works best? In patients with a prior elliptical ring, which valve works best? What we're trying to do is now put valves inside these rings, put valves inside these other valves, and sometimes when there's native mitral stenosis, with calcium, how can we put a valve inside here? And so all of these things are things that we're thinking about on the mitral side to try to get this whole field to move forward. But those are some of the unmet needs and some of the other questions that we're still trying to figure out. But at the same time, what's happening is that as we figure this out, this is what's changing the paradigms. Because what happens now is that today, a surgeon doesn't think about what valve they're going to put in for the next 10 years. They're thinking about what valve they put in for the next 20 years, for the next 30 years, because they're thinking to themselves, if I put in a mechanical, there's no way for them to put a valve inside of it on the aortic side. But also on the mitral side, can they fix something that's an issue by putting a valve inside of it or not? So the odds are mechanical valves will definitely change based on how this whole thing will proceed. In addition, people are also, I just heard in the past week that Cedars, at some point, there's a guy there that's thinking about trying to figure out a way to make a mechanical valve where you can take the leaflets out percutaneously to put a bioprosthetic valve in later. The whole field of what's actually a mechanical valve, what's a bioprosthetic valve is actually emerging, and it's becoming a valve that can be then changed and treated for the patients as they come in the future. Let's move on to something else, left atrial appendage technology. And for people that know about the whole Watchman story and what's happening on this is something that's pretty fun. And so the whole story behind this is really prevention of stroke in patients with atrial fibrillation. And what's happening is that we're really closing off a region of the heart highly associated with blood pooling and stasis. So just like you read about or heard about atrial fibrillation, what's happening there is that these abnormal heart rhythms are causing stasis problems in the atrium. And then there's a small outpouching of the atrium called the appendage. And so blood pools there, doesn't come out. Blood pools there, doesn't come out. Over time, that stasis ends up to coagulation, and that coagulation ends up to free-flowing embolism, and that embolism can go to the brain and cause stroke. And so you see here, this is a thrombus in the left atrial appendage. This is about a good 2.5 centimeters in diameter. And if you think about our carotids also around that same range, you can think about how much damage this is going to do when it goes into the smaller blood vessels of the brain. These are all the different left atrial appendage devices that we know about. There's actually many more than this, and the Mayo guys have definitely have their own as well. But you can see the original device, which is the Plateau device. Then after that, you have some of the ones from St. Jude, and then you have the Boston device over here, which is the Watchman, the Lariat device, and then you have the Prolipsis as well as the Coherence devices over here. There's really two different approaches. One is endocardial, and you go from the vein, you go up into the right atrium, you cross into the left atrium, and you're now putting a space occluder into that left atrial appendage. Advantage, one axis in the groin. Disadvantage is now you have this device which is forever associated with blood in some capacity unless it endothelializes over, and that you'll have to watch out for that. Epicardial is a closure device from the outside, either from the pericardium or by thoracoscopic insertion, namely lariat and atriclip. Advantage is there's no device exposed to blood. Disadvantage is you have multiple access points and a certain higher level of access that needs to happen to make this work. Unmet needs, so imaging. We're still right now slaves to this transesophageal echocardiography, which is not a small thing, because this is the best to rule out thrombus, it's the best to get appropriate sizing, and if the sizing gets wrong, then you have a risk of embolization. But this still means general anesthesia, this still means adding a second person to the whole table, and when you have an imaging person and an interventionalist person, guess who wins out when it comes to scheduling? The imaging person is the most important person in the room. I, as an interventionalist, cannot make any scheduling unless that imaging person is there. That imaging person is gone, the anesthesiologist is gone. There's nothing that I can do to get this procedure to go at this point. That's a huge issue. That's an unmet need when it comes to left atrial appendage. How about intracardiac imaging? Great, people have done this, people have moved this forward, and this is starting to really pick up steam. But it doesn't really have 100% the way to rule out thrombus, and there's still issues for depth and other things that we still have to operationalize to make this go forward. And overall, peri-procedural imaging benefits will drive the pre-procedural and post-procedural screening requirements down. So the better we get at peri-procedural imaging, the less we'll have to do the pre-procedural imaging, the less we'll have to do the post-procedural follow-up, because we'll have such a great idea of how things work. Another one, long-term thrombus protection. Whenever we have a device that's there, we place these endocardial devices and we give 45 days of warfarin therapy. And then after that, do a TE. If they don't have a clot, if they don't have a significant leak, we downgrade their anticoagulation to aspirin and Plavix. And that's it. There's no mandate to check again after that 45 days by transesophageal echocardiogram or by anything. What happens from there on out, because transthoracic echocardiography doesn't pick that up. How are we sure that they will not form a clot at 5, 10, 15, and 20 years? And how do we not sign them up for an invasive study or something else to try to figure that out? If we can make a transthoracic echo probe that can then isolate and visualize a left atrial appendage carefully, that by itself is going to be a whole game changer for this technology, for pre-procedural screening, actual procedure, as well as post-procedural follow-up. So I've just gone through 3 different technologies. There's much I can talk about perivalvular leaks and so on and so forth, but I want to go on to this other part of kind of what I wish device companies or designers knew, or rather kind of what, for tongue-in-cheek, I'm going to just put out some commandments from or really just things I wish would probably be better off. So number 1, and I think I'll go back to Paul for this, is thou shalt watch live cases. And the reason why I put this out there is that it's great to watch animations, but just like I showed you, what I'm thinking when I read it and when I see an animation is very different than how I'll actually see when I'll actually do a live case. And I say going in person to a site is much better than going to see a live case and it's much better than going to watch tape cases. Because when you see a tape case, everything is filtered. We filter out all the time that we wasted, we filter out the things that took too long to get done. We've cherry-picked our patients, we made this amazing audiovisual product. When we do live cases, we've cherry-picked our patients. We figured out who's going to be easy to go. We figured out who's going to be stable. We figured out so many different things. We, in fact, many times, sometimes they say, oh, we just, we're live now, so we've already done all the basic stuff, and here are some images that we want to show you because we've already started the case, and now we're at the key portion of the procedure. All that beginning stuff is gone. All that beginning stuff of the real life, how we actually figured out how to get to that point is gone. And so that's why even better than a live case is just going and saying, hey, can I come to your lab for a little bit? Can I come and watch and see how you do these things? And most of us, especially for you guys who end up designing the devices, are so open because we want to actually have your feedback. We want you to see what we're doing. We want as real life as possible. Many are online. And remember, if they are online, we're only really putting our best work in public. We're egotistical and all sorts of things just like everyone else. And we have a nice publication bias on our end when it comes to live cases as well. Look at case reports and complication cases at conferences. When you see how people handle complications, you'll see an opportunity that was missed, either on the pre-procedural planning or the imaging or something during the procedure, and you'll see that and you'll know how to make this device better. Look at European and US centers, they're very different. The number of devices that people have access to on the European side is more, but by the time things come to the US operationalization of the procedure is much better. So for example, I've done the direct flow valve in both centers, and when we were doing the direct flow valve over in Europe, and I remember how the proctors and us were interacting, it was very different than how the proctors were interacting over in the United States, because they have done so many more cases. Now things are operationalized. Now there's a nice little set of, these are the best techniques that you should do. But thankfully, if you are in the US, they figured out 95% of what works. But that 5% inventiveness of what to do in an unknown situation, a lot of times the Europeans are better at that. So they're so different in terms of how they do on each side of it. When we really see what we see, when we see it, understand why our hands move when they move, and then really the device, I think, will design itself. And as a plug for our conference that we have in June, we have 40 live cases of congenital structural intervention every year, and this is one of the reasons why Paul is such a big fan. Second thing is that thou shalt use 3D, but don't be dependent. And the reason why I put that out there is I saw some amazing 3D printers, and that's great. I think that's fantastic. I'm a big fan of 3D as well. 3D designing can be extremely helpful. And the reason is you can model 100 cases of a pathology and get an idea of what the device sizes should be, which is very new and very different than anything we've ever had before. However, I can tell you, we have at least 3 cases of aortic stenosis that presented to my one center at Swedish that I don't have a valve to fit them. They're just too big. So that means that there's something there outside of what the 3D data set can give you. That's what real life is. And if you take the 3 at my center and the 3 at the center next to me and the 3 at this, 3 at that, that's a whole different group of population that's just undertreated because no valve size fits for them. In addition, systole and diastole change ideas of sizing, imaging, and motion. While it's great for orthopedics to be able to use 3Ds, and great for people to have tracheas to be able to use 3Ds, great for people to have parts of their brain to be able to use 3Ds, and everything is great and so on for the vascular world. For the cardiac world, it's so different. What happens to the systole and the diastole sizing of even the aortic valve, which is really a very stable structure of just millimeters apart, that by itself can lead to issues when it comes to leak, much less the mitral valve, which is very dynamic when it comes to systole and diastole, the tricuspid valve, and so on. We'll give you an idea of how to get there, but it's not going to be the take-home when it comes to that. Another one, thou shalt plan for your first-in-man cases, but understand when they really differ from your ideal. And one of the best situations I have for this is that the first transcatheter aortic valve replacement case was a patient in cardiogenic shock with no other options. And if you look at the 2 stands, I think from Edwards that did a lot of the device development in the early days, he has a great TED talk about how he got that phone call from Cribier, and he said, yes, this is the patient, this is what we have to do. He's thinking to himself, wow, how are we going to risk everything that we have done on this patient? What if it does not go well? What happens then? What do we do? What do we do? And so much doubt came through his head when he was talking about it. It's a great video. But really at that point he said, well, these patients have no options. They're not really ideal patients for the therapy. But this is exactly what we still want to do. We want to show what happens in this situation. We want to know. We want to learn. And sometimes that's very important for a first-in-man case, especially when we are dealing with diseases that are life-threatening. And this is what happened on the mitral valve side, right? We have an early mortality rate of at least 30%, and in some cases 50%. A lot of times I don't blame the technology for it. These are people with New York Heart Association stage 4 heart failure. They have EFs about 30%. They have LV dimensions that are huge. They're barely going to make it through any procedure that you put them through. And now you're putting them through a transapical puncture or putting in a mitral valve and seeing how they do, right? So we understand that, we know that, but this is some of the things that first of will really entail. Another one, I really hope that everybody really watches your devices in a live setting, even after the trial is finished. I mean this from a commercial standpoint, not from a trial standpoint, but from a commercial standpoint. For example, Amulet, which is a left atrial appendage product from St. Jude, had problems with a connector pin in the first generation. So it was done with the trial, we were doing a live case, we were pushing it through, and it gets unhooked inside the delivery sheath. It gets unhooked inside the delivery sheath, and this wasn't the first time it happened. It happened a couple other times. The company ended up pausing the whole Amulet series until they figured out that somehow the way that it was going through the sheath was actually causing an unscrewing phenomenon. So then they had to rechange that to make that work out. The Watchman Flex, which is another left atrial appendage technology, just for the past couple of weeks is being held back now because it has a 2% embolization rate. They changed everything, so no longer they don't have any more of this depth issue where the depth had to be a certain point to deliver the Watchman technology. They got rid of that with this new Watchman Flex. It's much easier, much more deliverable, but now they have a 2% embolization rate. Now they're really trying to figure out what's happening, why are the hooks holding, in what direction, was an imaging issue or whatnot, and I commend the tech company for doing this, but this is why it's important to still follow this even after the trial is done, because the trial is really done with a few centers by very, very well seasoned operators, and it's really kind of an ideal setting to try to get this through to market. But once it's in market, that's when we really know when the rubber hits the road what everyone is going to do with it. The only thing that is predictable is that the unpredictable can and will occur. Another one, you shall judge continually what is clinically effective. Don't take what's dogma. For example, MITs. Transcatheter aortic valves will fly away because they're not sutured in. People used to say this. Left atrial appendage will cause necrosis of the appendage, and then you'll have issues with atrial natriuretic peptide, which is made from the left atrial appendage, and this is why the whole thing will fail. People end up in heart failure. Didn't happen. Current myths, tricuspid regurgitation. I mean, I was involved in some of the tricuspid regurgitation studies that are coming out from Europe with some of these devices, as well as some of the things that are happening here. And I remember when people were saying, how much tricuspid regurgitation do you need for this to be clinically successful? And then we said, well, we don't know, because when it comes to surgery, they're getting it down to trace or mile, but we're at best just getting it down one grade. So from grade 4, we're getting it down to grade 3. And so then we're saying, okay, but maybe these patients are doing better. It seems like they're doing better. That's fine. And so now across the board, it's starting to become this dogma that people are saying, oh, 1 grade reduction is great. But I'm thinking to myself, how did we get here? What proof do we have to know that 1 grade reduction is really all we need? 1 grade reduction is all we need if you want to actually show that your device has a greater than 50% chance of success. You make that threshold so small for you to be able to reach it. It's so easy. But you really should reevaluate and say, okay, does it actually pass the sniff test of surgery that really would accept trace to mild? And on this side, we're only accepting it down from severe down to moderate. Is we really doing what we're saying we're doing? If it is, great. If that's all you need to do, fantastic. But really try to figure this out, especially in the early stage. And surgical TAVR valves, do they really last as long as we think they do? For example, what happens with the early thrombus formation, that trial that came out that's showing that thrombus formation happens on both TAVR valves as well as surgery valves. Originally, the Portico program was all put on pause because of the TAVR side, and then they figured out it was happening on the surgery side. So these myths are very important. And what I'll tell you is true is that what physicians say now is different than what we will believe later. We will obviously say something to device companies and device designers right now, and then 6 months, 2 years, 3 years, we'll say, oh no, the whole time around we knew that tricuspid regurgitation really requires a 2.5 grade reduction. I have no idea why anybody would ever think otherwise, right? That's really how short our memory span is when it comes to this stuff. Another one, also remember, always imaging, imaging, imaging. Even if it's the best device, it may still not be placed correctly because of imaging. Fluoroscopy and echocardiography have a long way to go, as is fusion, and devices should be visible on both but not shadow other anatomy away. That's really important. And a couple more. You shall know that we'll go crazy. We really will. We'll do things off-label due to patient necessity as much as we possibly can. TAVR for patients with aortic insufficiency. TAVR through the transcaval approach, going from the right femoral vein to the IVC, to the aorta, to the aortic valve. That's really almost crazy talk when it comes to how this came about, but we still did it. Atrial septal defect device to the left atrial appendage closure. Vascular plugs for paravalvular leak, or even leak after percutaneous mitral valve repair. So Cybele, a good friend of mine, has done mitral clips, and we found leak that happened even after mitral clips. You put a vascular plug next to it. So now this vascular plug is floating with the mitral valve is opening and closing. It's just, how did we get here? But it works. So people, based on patient necessity, if other options are not available, will become very creative with the devices that you never thought they would do in the first place. And so other things, you will want to make it as simple as possible, but sometimes we can handle it being complex. So MitraClip, when it came out, was impossibly complex, but now device times are less than an hour. TAVR, when it came out, they went transeptal and went into the right ventricle, the left ventricle, and then out the aorta, and yet we still did it. We'll show that it can be done, then we'll make it easier, faster, and safer. And we'll trade complication risk for overall success if we can manage the complication. On the left atrial appendage side, pericardial tamponade happens. And we were taught in med school that pericardial tamponade is one of the 5 lethal causes of chest pain or hypotension. People die from this. But then we said, and this is a stroke prevention procedure, so we really want to minimize any risk that happens to this patient. We learned we can drain the fluid and the patient still does well, so we got better and better at it. And now it's not that big of an issue. Access is our mousetrap, and that really comes back to build a better mousetrap. You need to know that access will always be an issue, and you can focus on the end device as much as you want, but if the access is not working out, the whole thing is going to fall apart. And do no harm, the risk of hematomas and bleed is not small. And remember, why is this such a big deal for us? Because access is the one thing that's seen by patients' families, and the referring physician. It can be a fantastic aortic valve, a fantastic mitral valve, but I still have a little bit of pain in the groin, or I still have something it's just red. It just hurts when I walk still. The whole thing is just mitigated by that as far as the patient is concerned. Always answer new questions whenever they come up, such as durability is a big one. In TAVR, we answer questions about stroke, death, and negative outcomes, but as we get into low risk, durability is going to be more important. Durability does not fit into a 5-year study timeline. You need longer studies out to 15 years. And the first that proves this is going to really take us out to market as far as the low risk goes. Same for other valves, same for left atrial appendage devices. Know what we expect. So iteration will be acceptable because our needs are so high. We expect that for mitral valve, it's going to be complex for another 5 to 10 years. Same for the tricuspid. We know this. We accept that from you guys. We don't accept the same for TAVR or for left atrial appendage. And at the end of it, it really all begins and ends with you guys, with device design. And it's the idea and the thought and the inspiration that brought us these devices that we have today. So we have a very healthy respect for you doing what you do. We're extremely grateful and appreciative for everything. Thank you.
That was awesome, very inspiring. Do we have a couple of quick questions?
Great presentation. I was looking at your statistics for the TAVI implants. So even with anticoagulation, you still have 2 to 8% stroke risk.
Yeah.
What's your hypothesis on the mechanism?
So there's some good papers on that. The reason why I brought it up to even 8%, if you look at the intermediate risk data, when they looked at what stroke happened, they said stroke was even happening up to 6% of the time. And so for S3 and some of these valves and these very specific studies for CE mark, you'll see it as 1.9% or something like that. So why is it up to 6% or other things? Number one is people with atrial fibrillation is a huge issue. When do we anticoagulate? What's happening? And when is this stroke risk happening from that standpoint? Number two is patients with progressive artery disease are picking up. Number three also is that you do a prior balloon valvuloplasty that can also put people into stroke risk from that standpoint. Repositionability of these valves, does that add to this? All these things are small little hints that we have that this could be adding to stroke, but at the same time, on the other end, do deflectors and all those capture devices really make a big impact? If only 50% of the strokes are happening during a peri-procedural time period, we still don't know.
Jacob Bergson from Oslo. You didn't mention chordal implantation or the poor configuration of the left ventricle in your talk. What is your opinion on those?
Chordal implantation definitely has a good role, and we've done cases with NeoCord device as well as a few others. It's definitely very straightforward, and when it works, it's great, but at the same time, what these cords are going to attach to, which patient is going to be the right one for that versus a mitral clip, you know, it's very still to be determined. And I think that's something that has a place within it, just like it has within surgery, but I don't have a great answer as to when that will all play out.
I have a quick question. When you do all these transeptal procedures and the bigger devices like the mitral down the road, I don't know if they'll ever get down to 14 French, are you going to worry about closure of these?
So the people from Cedars put out a good paper talking about what happens when you have these closure issues. If you're still having left to right shunting, but if the QPQS, which is the shunt fraction, is very low, then that's fine. If that's not a big issue. When you start having right to left shunting after a case, then people start worrying about it, and then they end up thinking about closing those defects. And that's just one paper, but there's no standardization across the board to make that an issue. At the same time, some people have actually looked at it from the mitral side, specifically saying it's a blessing because now you have offloaded the left atrium. Now you have less pulmonary pressures going back from the left side. That's what's actually causing a lot of the benefit.
Well, let's thank Dr. Gafoor once more.
Thank you.